I think it's important for us to remember, especially when it comes to things like insomnia, that in reality, change means stress. All too often, people have too narrow a view of stress. We tend to think of stress as just what we're worried about or what's on our mind. And in reality, stress is anything that provokes a response. And so with this definition, we can see the pain of the headache is a stress. Not getting a good night's sleep is a stress. So it becomes important for us to realize that things that stress us, such as poor sleep, will have a direct role on our sensitive brain, making it easier for us to have more headaches. Now, we might ask, since the talk is entitled Headache and Sleep, why don't we talk about other headaches? Well, there are other headaches that have a very strong sleep component, such as cluster and hypnic headache. Hypnic headache also goes by the name alarm clock headache. Typically seen in older people, they will awaken 30 minutes before usual, and this headache lasts for a couple of hours. The reason I didn't want to talk about these is these headaches are not very common. They're not usually going to be seen. And when we look at cluster in particular, while it is a very devastating headache, for every one person who has cluster headache, 120 people are going to have migraine. So migraine is a much more common and predominant condition that I think it's better for us to focus our attention on. But it's also important to think about the person who has this sensitive brain. And the father of American medicine, Sir William Osler, said it's much more important to know what sort of patient has a disease than what sort of a disease a patient has. Because while you may have that sensitive brain, those things from your past may have a role in your headache. The things in your current environment, other conditions that you have will also influence your treatment and what you need. And when we look at the running buddies of migraine, what we call the comorbidities, those conditions that we see inside of migraine at greater numbers than what we would expect by just chance alone. We see a lot of the mood disorders, depression, anxiety, bipolar disease. We also see a lot of insomnia and fibromyalgia. And we find a commonality among these conditions in that the neurotransmitters are very similar. The same areas of the brain are very similar. So it's easy for us to understand the commonality of these conditions and how they're very often linked together. And so as we link all of this together and put it all together, we can see in this great circle of things that will influence the headache and neck pain at the top of the circle, things such as the medical comorbidities, stress, psychiatric comorbidities, insomnia, medication overuse. All of the comorbidities influence each other. And so it becomes important to identify and develop a treatment plan for those items that are making it easier for us to continue with the headaches. And fortunately, many of these comorbidities have similar treatments. Common treatments for insomnia include relaxation therapy, biofeedback, exercise, pharmacotherapy. These are things that can help with psychiatric comorbidities, excess levels of stress, and other medical comorbidities. Now, when we look at the basic sleep stages, we have now broken it down to what we will call 3 stages. Stage 1 sleep lasts about 5 to 10 minutes. It's the lightest stage of sleep. It's the easiest interrupted. When you're in stage 1 sleep, someone walks in, calls your name, you're going to awaken. At stage 2, we start to see a decrease in the pulse and the body temperature. We see a slowing of the brain waves. On an EEG, sleep spindles start to appear, but you're still easily awakened at this point. And after you've progressed through the stage 2 sleep, we start to enter what we call a slow wave sleep. And this is a stage 3 sleep. We used to call these stage 3 and stage 4, but because of the similarity between the 2 stages, they move them together. In stage 3 sleep, we see a decrease in metabolic activity. delta waves start to appear on the EEGs. It is difficult at this time to awaken someone, and once awakened, they were unable to recall any dreams. As the stage 3 progresses, we start to have our restoration. We're disoriented if we're awakened. And before REM sleep starts, the rapid eye movement sleep, we see delta waves almost exclusively. And at the development of the rapid eye movement sleep, our breathing becomes rapid and shallow. We see an increase in our pulse rate. And brain activity is very similar to the awakened state. And this is a time when we dream. Now, when we look at the sleep stages, this cycling from stage 1 to rapid eye movement will typically run about 60 to 90 minutes a cycle. And this is a sleep architecture, a structure. And we will have between 4 and 6 cycles a night. To have good sleep, good restorative sleep, we need a sufficient number of cycles with architecture maintained intact. We believe our rest and metabolic restoration starts to occur around stage 2. And getting to the stage 3, what used to be stage 3 and 4, and REM, this promotes learning and memory. Now, when we look at the various ways that sleep can go wrong for us as it influences headache, we see several different conditions. We see insomnia, sleep-disordered breathing, restless leg syndrome, a shift work sleep disorder, and bruxism. Now, insomnia has several different components. You can have trouble falling asleep, taking more than 20 minutes for you to fall asleep. Once you've decided it's time, head hits the pillow. There can also be trouble with sleep maintenance. I just can't stay asleep. I'm waking up all the time with a difficulty in getting back to sleep. And it's lost on most people that it's actually normal to wake up several times during the night, but usually in someone who is sleeping well, they'll say, oh, it's night, I'll roll over and just go back to sleep. It would be defined as insomnia if someone has difficulty getting back to sleep. Now, insomnia can also be, in a nutshell, it's a non-restorative sleep that impairs your ability to function the next day. It is usually what we call secondary, and secondary means it is caused by something else. Very rarely is insomnia going to exist by itself. Now, another sleep disorder, which is very devastating, is sleep apnea. And there are several types of sleep apnea. There is obstructive sleep apnea, which means the airway itself becomes blocked. We will typically see this in gentlemen whose neck size is over 17 inches. These are very loud snorers. This is typically treated with a continuous positive airway device, or CPAP. Can also be treated with what's called BiPAP. Weight loss can be a treatment for obstructive sleep apnea. But we can also see some individuals who have a central sleep apnea. And what the central sleep apnea means is just the brain itself is not sending that signal to take a breath, or it's not sending it consistently enough. Now, it's thought that the apneas are clinically significant, meaning it's impacting your health if you have an apnea hypoxemia index of greater than 5. Now, what this means is that in the space of an hour, that you would have 5 episodes where you stopped breathing to the point that the oxygen levels in your blood dropped. If it's less than 5, they may say, we may not need to treat this, but observe this and see how you're doing. But when it's 5 or more, this requires treatment. Now, it's thought that about 9% of the women and 24% of the men between the ages of 30 and 50 years of age have sleep apnea. These are very, very high numbers. And you can also see snoring without apnea. This is a risk factor that's been linked to migraine progression. And very often I will ask my patients, well, do you snore at night? And they give me a strange look and say, well, how dare you accuse me of snoring? And I say, well, you're asleep. How do you know? But this can be something that is contributing to non-restorative sleep, lowering a threshold for headache and making it easier for you to have more headaches. Now, we can also see restless leg syndrome interfere with sleep, and this is described as a deep, unpleasant crawling sensation in the legs, typically occurring at night, especially at bedtime, and it's relieved by voluntary movement. And it's thought that about 5 to 10% of the people in Europe and North America will suffer from restless leg syndrome, and it significantly disrupts sleep and quality of life. Now, shift work sleep disorder is another problem. I don't think that we were built to work in shifts. I remember my grandfather used to work in the refineries, and when he would work the graveyard shift, I would ask him, Grandpa, why do they call it the graveyard shift? And he looked at me and said, son, that's because only the dead should be out. And we can see that when we get people out of normal patterns, we can get into more trouble. And shift work sleep disorder is an alteration in the timing of the sleep. If we shift what time our bedtime is, any problems in sleep can occur. There can be trouble with onset, trouble getting up, daytime sleepiness. A type of shift work sleep disorder is jet lag. Now, when we have this, we can adopt some therapies such as bright lights early with awakening, using melatonin. This can be important. You will also see some people try to go back and forth very often, like I will do 5 days of nights, and then on my days off I want to spend time with my family, and then I go back to nights. And for someone with migraine, this can be a recipe for disaster, because that migraine brain wants order. It wants going to bed at the same time, getting up at the same time. We can also see bruxism, which is a movement disorder that's marked by clenching of the teeth and grinding, and it's typically occurring during non-REM sleep. It is seen a little bit more common in children, about 14%, and about 8% in adults. And it is associated with stress or anxiety, and you can find people this will be where they'll carry their stress. Now, for me, the importance of sleep in chronic migraine was driven home at the first National Headache Foundation meeting that I attended. One of the award-winning papers that time was done by Dr. Ann Calhoun and Dr. Supata Ford. And they were presenting the results of a study that they had done with 45 consecutive females coming to their clinic who had chronic migraine. And they said, we're going to do a study on sleep and chronic migraine, and we would like you to participate. They said it's a 12-week study in 2 6-week parts. And out of 45 people they offered the study to, 43 said, yeah, we'll do it. So what they did is that they divided the women into 2 groups. There were 23 in the active arm who were given behavioral sleep modification instructions. The other 20 people were given what we would call sham instructions, things that sounded reasonable but would not have any impact on an individual's sleep. The study design was a single blind, which meant the patients didn't know what was real and what was sham, and this was broken at 6 weeks. And all of the individuals who were then in the sham study crossed over into the active arm. So at the end of the study, everyone got the active treatment. And when we look at the 2 groups, We can see the age was about the same. In the group that got the behavioral sleep modification, they were 33.5 years. The sham group was 35. How long people had had migraine? We could see in the active arm, it was 140 months, and it was 116 months in the sham. So you're looking at people who had had these serious headaches for 10 years or more. The headache frequency was very similar, with about 24 days out of the month in the behavioral group and 23 in the sham. And the HIT-6, which is a measure of headache disability, was very similar in both groups. Now, the active instructions were simple. Schedule consistent bedtime that allows 8-hour time in bed. Eliminate TV, reading, and music in bed. Use a visualization technique to shorten the time to sleep onset. Move supper to 4 or more hours before bedtime, and limit fluids within 2 hours of bedtime, and stop taking naps. And what we could see in these two arms, we had 43 women who were randomized, 23 to active, 20 to placebo. At the 6-week follow-up, 3 of the 23 were lost to follow-up, which means they did not follow up. At the first 6-week period, 35% of the women reverted to episodic migraine. So just improving their sleep, 35% of the women got better. And in the sham arm, none got better. Then at this point, crossover occurred, and the people who were in sham received the true instructions. And 6 weeks later, 58% of the people in the 2 active arms reverted back to an episodic migraine pattern. And in the sham arm, which had only been working on 6 weeks, we saw 43% reverted to episodic. And if we think about this, with all of our other interventions that we have before us, whether it's Botox, Topamax, amitriptyline, propranolol, this is an incredible response to cutting the headaches down by one intervention alone, and that is improving sleep. Now, when they looked at the adherence, how well people followed the directions or that they were provided, they were very similar between the two groups. And what they saw is that those individuals who adhered to all of the instructions, they were the ones who got the best. In the first group, 7 out of 8 who followed all 5 instructions reverted to episodic. If you only adhered to less than 3, you had no improvement. So you not only had to get the instructions, you had to follow them. And so if we think about it, we go, why is this important? I always will tell my patients, I think it's important to understand how you got to where you're at and what's keeping you there. And so if we apply this thought to our sleep, and when we look at how important it is, because when it gets corrected, headaches get better. More than that, they get much better. Why are we having trouble doing one of the most natural things in the world? Sometimes we can get into bad habits. Sometimes there can be a history of a past trauma or a post-traumatic stress. And I think we have to have an understanding of how we got to where we're at so we can see what it is that we need to do. So what are the different things that we can do related to sleep? There can be relaxation training. We can have cognitive behavioral training. Stimulus control is important, controlling our environment to create this environment that's conducive for sleep. We can have sleep restriction and sleep hygiene education. And so if we talk about the relaxation training first, this is highly physiological, cognitive, or an emotional arousal. This is, I can't shut my mind off. There's too much stuff going on. I just can't stop. relaxation training can help us to calm down that physiological excitement, that mental excitement or emotional arousal. Other techniques that are part of relaxation can include progressive muscle relaxation. This is where people will tighten a muscle group and then relax and then move that down from the top of their head to their feet. We can use EMG biofeedback. You can also use what's called autogenic training, which is a repetition of relaxing and calming phrases such as, I am quiet and relaxed, I am at peace, my right arm is heavy, my left arm is heavy, I am at peace. This is kind of learning and getting into a ritual of relaxation. Cognitive behavioral therapy is used to calm down the racing or excessive thoughts around the bedtime. Catastrophizing, which is, oh my God, it's never going to get any better, it's always going to be this way, or, oh, I'm never going to fall asleep, and belief creates the actual fact. And what we have to do is to recognize and challenge and replace these irrational thoughts. And this is a role that cognitive therapy can have in improving our sleep. Now, stimulus control is creating this environment that helps us sleep. And this can help with the delayed sleep onset. It's harder for me to get to sleep at night. This can also help with sleep maintenance. I have trouble staying asleep at night. And what we need to do is to go to bed only when sleeping and I'm intending to fall asleep. So don't go into bed and read. Don't go to bed and watch TV. Don't go into bed and eat the nachos. And if you're not able to fall asleep in 10 to 20 minutes and not looking at the clock, then what you need to do is get out of the bedroom and only come back in the bedroom when you're sleepy, when you're ready to try to go to sleep again. And you really only want to use the bedroom for sleep and adult intimacies if you're having trouble sleeping. I mean, I'll tell my patients, if you're not having trouble sleeping, you can have a mariachi band in there, and I don't care, as long as you're rested when you get up. But if you are having difficulty sleeping, you need to have an environment that is conducive for sleep. You want to set your alarm and get up at the same time. Don't keep hitting the snooze bar, because you do have to have a sufficient amount of sleep inertia later on for you to be able to fall asleep. And you do not want to take naps during the day if you're trying to adhere to a stimulus control. Now, if we look at sleep restriction, sleep restriction can be kind of brutal. It's hard to do, but it is an effective way of retraining your brain. And this may be something that pays off for people who are having significant sleep difficulties. And the carrot that I would hold out for sleep restriction is going back to Dr. Calhoun's and Ford's study and look at the improvement in headaches that people got when their sleep was better. And what you're trying to do is to build sleep habits. And the goal with sleep restriction is to avoid excessive time spent in bed when you're not sleeping. And this is to help fragmented and poor quality sleep. And you use sleep diaries to determine the amount of time that you're spending in bed and the actual time in bed. And you restrict the time in bed to the approximate average number of hours of actual sleep time per night with a specific bed and wake time. When the diary starts to show that actual sleep time is 85% of the time in bed, then you increase in a 15 to 30 minute increment. And you need to keep a fixed wake time regardless of how much actual sleep duration. And in the beginning, short nights are going to be expected. And this is part of what is needed for success, because this increases that sleep drive, sleep inertia on a subsequent night. And so you can expect this as someone's getting 2 or 3 hours of sleep at night. They're going to be very tired at the next bedtime. And this is what's needed to retrain the brain to get them back to sleeping. Now, if the sleeping time is less than 85% of the time in bed for 10 days, you've got to restrict the time in bed further by about 15 to 30 minutes. Now, sleep restriction can be kind of brutal and hard, but what's going to make a difference is commitment. in understanding this. Now, general sleep hygiene instructions, what we want to avoid is any of the previous or poor general sleep habits that we talked about. We want to avoid daytime naps. We want to eliminate stimulants such as caffeine and nicotine. Maintain a regular bed-wake cycle 7 days a week. And this is especially true for people with migraine. You don't get to sleep in on Saturday or Sunday. You need a dark sleep environment. You need to limit alcohol intake. Regular exercise is important, but you really should avoid exercising about 5 hours before bed because the exercise will tend to raise your core body temperature, and that will shift out the ability for the body to fall asleep naturally. And we only want to use the bed for sleep and adult intimacies, those behaviors that can be conducive for sleep. Now, I think that there are some very valuable resources that can help us with sleep. And I wanted to talk about some of those now. And what I would encourage that you do, I think Amazon is a good place, Barnes & Nobles is a good place, but go online and read the reviews of these books from people who are having difficulty sleeping and see if you see yourself in any of these reviews or evaluations. And choose something to help you sleep. Because if you're not able to fall asleep in 10 to 15 minutes of your head hitting the pillow, you can say you're having trouble doing one of the most natural things in the world. And there should be a reason for this. And when we understand what's important in our sleep, then we can start to address those things that are getting in the way. And especially with migraine, we can see the importance of getting that good night's sleep and how it is linked to getting our headaches under better control. Now, my personal favorite is Say Goodnight to Insomnia by Greg Jacobs. Dr. Jacobs runs a sleep clinic at Harvard, and the main theme in this book is that bad sleepers aren't born, they're made. And when they look at the people who've gone through the program at Harvard or have used the book as a guideline, or there's even an internet program that Dr. Jacobs has, which is called cbt4insomnia.com. All of the people who go through the program will tell you, I'm sleeping better. 90% of the patients say, I can throw my sleeping pills away. And 75% of the patients say, I'm a normal sleeper again. And I've seen this particular book help people from age 18 to 80 with their sleep. And it's got average 4.5-star rating with 181 reviews at Amazon. And it's out of the Herbert Benson Mind-Body Institute at Harvard. Now, No More Sleepless Nights is also a very positive book. It's also available on audiobook for some people who have difficulty reading. Peter Hari used to be the director of the sleep clinic at Mayo. The director of our sleep clinic here at Scott & White really likes this particular book. And it is a good book, and this is why I encourage people to look at the reviews and see which one speaks to you, because there are materials out there that can help you. Now, another book that can be very important for people with pain is this one, Quiet Your Mind and Get to Sleep. This one's a little bit of a newer book, whereas Say Goodnight to Insomnia and No More Sleepless Nights have been out for years. This one is kind of targeted specifically for those people who have that mood disorder, anxiety, or pain. And so this one may be a little bit more of an interest to the headache community, and I would recommend looking at the reviews on this. Now, another book that I found a lot of benefit, because I take care of a lot of soldiers who spend time in Iraq and Afghanistan. And this book is called the Post-Traumatic Insomnia Workbook. And there aren't many reviews on this, and I think it's probably because there are not a lot of people who know about it. But I've had this book since 2011, and I think it's an outstanding book that can really help people. And anyone who has had a traumatic event, this can significantly disturb your sleep. Because if you think about it at a fundamental level, our brains are wired to keep us safe, to get us into tomorrow. And if we've had that life-threatening event, no matter what it is, that part of the brain that's in charge of keeping you safe is saying, hey, buddy, I'm not going to let you go to sleep. When we're asleep, I'm not on guard, and I've got to keep us safe. And we have to learn how to stand down, how to use our conscious mind to calm the subconscious to let us go to sleep. Now, why am I talking about books? Why can't I just take a pill? Why isn't there just a pill for this? And the simple answer is kind of the same answer we see in migraine, is that there really are not any simple fixes. Because if there was a simple fix, it would have been fixed by now. And I will typically tell all my patients that all drugs are poison. It's just the dose. Too much water will kill you. Too much oxygen will stop you breathing. And anytime you use a medication to do something that the brain or the body does, the brain or the body will forget how to do it. And so taking a pill to put you to sleep every night, it will not take long for your brain to forget how to fall asleep. It will also make it harder to develop those skills that you need. And there's a specific problem with the medications used to induce sleep. Yes, they will chemically induce your sleep, but they will disrupt the sleep architecture so you do not get the restorative and the healing benefits of that natural sleep. Now, this is not to say that I don't use medications to help patients for a period of time, but I liken the medicines used to help people sleep to the training wheels that you put on a bike. They're to keep you stable and let you cover a greater distance than you could cover on foot while you are learning how to do for yourself what these training wheels are doing for you. So the medications can be a part of your plan, but only a part while you were working on learning how to be that natural sleeper again. And so this is the end of the audio part, and where we will take questions, and hopefully this won't be too challenging for myself since we had problems getting online earlier.
All right, it looks like our first question is from Eileen. She'd like for you to speak about hypnic headaches. She wanted to know if you could talk about how and why those types of headaches interrupt your sleep.
Well, the hypnic headache is typically called an alarm clock headache, and we'll typically see that in our older patients. We'll see this in the 60s and the 70s. Typically, it will go away in an hour or two after awakening. Caffeine will help. Also, lithium has been used to help. And one of the strangest things that I have, I guess, some trouble understanding is that they will give people caffeine at bedtime to help with the hypnic headache. And I'm just saying, wait, how am I going to take a cup of coffee at bedtime to help with the headache that I'm going to wake up with in the morning? But it's typically a headache that it's a dull type headache, not sharp. It will awaken in the patient in the morning, typically the same time of the day. And it will usually occur more days than not in the morning, and it'll last for 15 minutes or so after awakening. And you typically don't see any other signs associated with some of the other sleep headaches, such as tearing of the eyes that we'll see in cluster, or a lid lag that we'll call atosis. It's thought that it's problems with the suprachiasmatic nucleus or our biological clock that is a cause, but it's not very well understood.
Thank you. Our next question comes from Judy. What is the best and smoothest way to transition back from an up-all-night bad sleep to a good sleep?
To transition from an up-all-night, I'm not quite sure that I understand the question. I think once we all get to be about 30 years of age, every now and then we're going to have a bad night of sleep, and that's just whether it was something in the weather, something in the water, excitement, we were sick. And so I'm not real sure that that's the question. If we're looking at transitioning from I'm a poor sleeper to a better sleeper, I think trying to work this out with your physician to see is there something that can help with the sleep for a short term while you're working on proper sleep hygiene, looking at some of the sleep hygiene instructions and what are good sleepers doing. I remember the American philosopher William James, who's known for the as-if principle. And the as-if principle states, if you want a characteristic, act as if you already have it, and you will acquire it. So we ask ourselves, what are people who are sleeping well doing? And then we go and we start to do those things. We can look back at how is my stimulus control in the bedroom? Am I eating 4 hours or more before bedtime? Am I avoiding liquids? Can I practice some of the autogenic training? Do I need biofeedback? And this is where some of the books like Say Goodnight to Insomnia can really help. A fascinating tool also on YouTube, if you search the word weightless and Marconi Union, this is a video that has actually been shown to help people fall asleep faster. And you'll see the tagline, the most relaxing video ever, but it's called Weightless by Marconi Union. But I would look at adopting sleep hygiene instructions, and I really, just a little story on sleep. I've been married 28 years, and my wife was a good sleeper up until our son was born 23 years ago. And for about 8 years, she was just not sleeping well, not sleeping well. And then for some reason, she got upset with me because I could sleep well. And she said, I'm mad at you. You fall asleep real easily. And what do I do for my sleep? And I said, I'm not your doctor. Go talk to your doctor. And she said, no, I'm not going to talk to my doctor. They think all doctors' wives are crazy. I can't sleep. And so finally, after about a week of her really making an issue, I brought Dr. Jacobs' book home to her, and I gave it to her, and I said, here, read this. And within about 5 nights of her reading this, she had started sleeping again like she had not slept in 8 years. And a lot of it was behavioral, that she had picked up a lot of those bad habits that Dr. Jacobs talked about, that if you don't know that they're getting in the way of your sleep, why in the world would you ever do anything about them? But when you start to understand all of the things that are a part of your day that can get in the way of your sleep, then we can take steps to deal with them and get back to that restful, restorative, and healing sleep that we all need.
Thank you. Our next question. I was rear-ended by a truck about 13 months ago, and I suffer from daily constant headaches. I was jerked forward and back, and since then I've had difficulty with balance, light, and noise. My CT scan is fine, and the MRI of my neck is fine. I am on 20 milligrams of Propanol daily since May of this year. I am so frustrated because my headaches are chronic and constant all day long. I take Tylenol with caffeine. Is this good?
Well, I don't know that you're going to get better doing what you're doing. I think your sleep is definitely going to be something that needs to be addressed, and that kind of caffeine consumption is going to wind up interfering with your sleep over time. I'm kind of a lowest common denominator guy, and if based on what you're describing, what we can say that you most likely have would be a post-traumatic headache. And when someone has a post-traumatic headache occurring after a trauma, imaging is pretty much going to be normal. That doesn't mean you're not having the issue. It means that our imaging techniques aren't good enough to actually get down to the cellular level and see the damage that is taking place. And we know the neck is intimately involved in headache. Ann Calhoun, who we mentioned earlier, did a study out of the University of North Carolina several years ago where they showed that neck pain is more common in migraine than even nausea. And so we will see people with neck pain have more headaches and people with headaches have more neck pain. And it definitely has this bimodal influence where each one will influence each other. You know, my recommendation for you is it sounds like this post-traumatic headache has become chronic. And what you really need to do is to get in and visit with a doctor who is very familiar in treating headaches. And unfortunately, there just aren't that many of us. Right now, I think there are 416 certified headache doctors in the United States. And what you need to have is someone who's going to have experience this and getting an idea of what to do for you, because it's probably not going to take, there's not going to be any one thing in particular, but the way that we looked at all of those comorbidities there is that what has happened is that the trauma has changed your brain. It has sensitized it to where it is now a migraine brain, and the headaches you're having are basically the same as if you got your headaches from your mother or your father. And it really needs to be approached that way successfully. And there are a lot of things that can be done, whether it's some prescription medicines. For some of my post-traumatic patients, I've used IV magnesium. I've also used Namenda, which is an Alzheimer's medicine that's been shown to help people with post-traumatic headache and significant migraine. So there are a lot of things that can be done, but what you would really need to be with is a provider who has experience in taking care of patients like yourself.
Thank you. Our next question. I'm often woken up in the middle of the night with a migraine, and it takes me an hour or so to go back to sleep. Any suggestions on how to get back to sleep earlier?
No, that's always a challenge. I think it's important for us to recognize our patterns. You know, so I would wonder how often this is happening. Is this your typical pattern, or is this something that happens several times during the month? One of the things that we have learned is that there are prodromes before a migraine, and what a prodrome means is signs or warnings anywhere from 12 to 24 hours before you get a headache. And this is why keeping a headache diary can be very important, because what we can do the day after the headache is think back, how was I at bedtime? Did I have anything that gave me a clue that I was going to have a headache? Some common prodromes can be food cravings. It can also be irritability. Yawning excessively is indicative of a migraine prodrome. And so if we can get to where we can recognize that I'm in a prodrome, then there are some things that we can do. We have found that a couple of the nausea medicines like metoclopramide or prochlorperazine, that's Reglan and Compazine respectively, have been shown to abort headaches when taken in the prodrome phase. An important aspect, if we are awakened in the middle of the night, excuse me, especially if it's common, is to have our treatment close by and use it to try to stop the pain. Also, practicing our relaxation can also help us, because we're not going to hurt when we're asleep. One of the medications that I like to use for the middle of the night headaches is tizanidine, which is a muscle relaxer. The big side effect that I say that we see with the tizanidine is it gets people very sleepy very fast. And it also blocks ascending pain pathways, and I will use it frequently for acute headaches. But, you know, a 4-milligram pill can make people very sleepy and help shut off the pain and let you get back to sleep. And the tizanidine can do a good job of getting you to sleep, but it doesn't necessarily do a great job of keeping you asleep. So it's not something that would leave you, you know, hungover or medicine-y head the next day.
Thank you. Our next question, do you have any advice for restless leg syndrome?
Oh, gosh. It really needs to be evaluated because there can be several different things that can be a cause. Very often we will see restless legs in people who are anemic. And anemia can also be a perpetuating factor for migraine. Common treatments can be some dopamine agents, but also some membrane stabilizing agents such as gabapentin can help. But it really is something that requires a medical evaluation because you have to look for something that may be causing it. Restless leg can be idiopathic, which means we can't find what's causing it, and then we just focus on the treatment. But because it is caused by several different things, it's important to have that evaluated by your doctor, and then, if needed, referred on to a movement disorder or neurologist for evaluation.
All right. Thank you so much. Thank everyone for joining us, and have a great evening.